hear from, in no particular order, although I'm going to start with Richard, and then Nav, Tana and BE and Carl Brooks, who represent primary and secondary care, are sitting as close as we want primary and secondary care to be in the future. So thank you very much for joining us. So Richard, I think our audience would really like to hear from you first. Please introduce yourself as you begin, about your perspective on what are the current challenges in bringing patients more involved into their care. Thank you.
Yeah, well, you're a hardy crew, aren't you? Already, nearly 5 o'clock. I think we're all here just checking there's nothing happening at Westminster across the road so we can see anything, any latest scandal. So I'm Richard Samuel. I'm on secondment from an integrated care system, and I'm working in the care models team in NHS England. I nearly said NHSX, but the care models team in NHS England, with a particular focus on how we can use digital solutions to drive the elective recovery plan that was launched on Monday. You'll have read the plan, no doubt, or had sight of it in the newspapers or across the social media. And I think it's just a moment to step back and take stock of what I've heard today and what we've all heard today, which is this extraordinary vibrancy of capability that exists in all aspects of digital support. We can do more than we ever dreamed, and every year we can do more. And yet we're constantly challenging ourselves to say, why does it sometimes feel less than the sum of the parts? And how do we hook this together to make an impact on people? And to put that into context, our aspiration is by 2015, we get ourselves back to the position that a number of people were waiting for planned care in 2019. And Carl will tell you, it wasn't happy in 2019. We didn't feel like we were knocking the ball out of the park in 2019 in terms of the length of time people were waiting and the challenges and the brink of people waiting 52 weeks for care. And so 2019 is a kind of de minimum ambition to support people and their experiences around the planned care sector. So the work that we've been doing as part of engaging with ministers, with patient groups and others, talk about constantly digital and digital solutions lying at the heart of this transformational change. And one of the core pillars of that is, as we've just heard, how do we hook up digital to truly empower people to take control of their journey and their experience? And for us, you'll see in the operating planning guidance some of the consequences of that hooking up of technology and digital solutions to transform people and empower people to take control of their journey. But in terms of practical terms, what that means are starting to create single routes of access to information. We've seen the My Plan Care website launched. We're on the brink of using the NHS app as creating a single entrance into the health ecosystem to provide people with all the tools and support they will need that we've heard today around how they manage their own journey through the planned care system, from smart triage to booking their own appointments to reducing the need for them to traipse along to the hospital for pre-assessment consultation, for pre-surgical assessments, and to contribute to the co-produce the shared decision-making cycle, so that actually people are only choosing to undertake surgery where they feel their ownership rests in that cycle. And so the national policy, which we'll hear in a second, is about creating the foundational capability to hook up all of the solutions we've heard today, and importantly route it into the core electronic patient record and the PAS system, so that we're not having free-floating content out with the core electronic patient record, and then effectively liberating patients by giving them the control and power to book when they want to book, to understand their experiences much more effectively, to ask questions of clarification or content as they move through the pathway, to put them in control rather than a paternalistic cycle down. So I'm happy to kind of speak at length, but I think that's the key message for me.
Yeah.
Foundational capability with a targeted piece of work in 22-23, which is all about where do we make the biggest impact on waiting lists and the biggest impact on experience for patients next year.
Thank you, Richard. And I think what I heard there, we talk about empowerment as if it's an extrinsic thing that we are able to sort of give patients. I think it's an intrinsic strength and power that we want to offer our patients. And you're describing personalised care. So I suppose my question back to you is, what could the future of personalised care look like to you?
Yeah, so look, I feel a fraud standing up here because I'm surrounded by people in the audience and at the table who live and breathe personalised care on an hourly and daily basis. But clearly what we mean by that shift of personalised care is at every stage of the planned care journey, now thinking about how do we give control of the individual where that's possible and feasible without creating massive disruption to the workflow. And I think that's the kind of caveat. It is possible for us to entirely throw the pathway up in the air, but it would decimate our ability to drive a productive and efficient care pathway. So an example of that would be prior to any consultation process, patients are able to access shared care support tools, to co-produce the consultation, to set out their objectives and ambitions in going to the consultation, providing information that doesn't need to be gleaned during the consultation, and therefore, and then immediately securing the outcome of that consultation in digital solutions that allow them to know what their care plan is, what they need to think about, what they can do in order to optimise their planned care experience and maximise their outcomes and patient-reported outcome measures. What it means is that once you've had a surgical episode, and I had my knee done recently, I'm in control of my journey thereafter, and I'm not having to come along into a kind of paternalistic consultation to say, is my knee working? I'm following through a series of structured inputs, and therefore I'm making a choice as to whether I want to come for a consultation because something is clearly out with the norm, or actually whether I'm able to report my outcomes to patient through a system that dynamically creates that all's well, no need to follow up.
So I'd really like to bring in Dr. Carl Brooks and Dr. Nav Chana on this conversation. And I suppose the question to you both, and please introduce yourselves and kick off the conversation, is how can you, together, across primary and secondary care, work as a clinical community to really deliver and support truly personalised care?
Okay.
You're so polite.
Okay.
Go for it.
Well, if I can come to that in a bit, Mel. Just to Richard's point, the personalised care is a great idea. I don't think many people would argue with it, but the NHS has never done it. We restrict access to people. That's how we manage care. So every GP surgery has a Rottweiler who stops people coming in. Every hospital has secretarial departments that never answer the phone, and that's how we handle things. Okay, we restrict access to people's care. Now, if we are really seriously going to change to personalised care, I think there are two things. The information systems will have to change completely because every single outpatient clinic is booked up to the nine. So how are we going to fit someone who suddenly rings up and says, I want to be seen in the next couple of days? We have waiting lists for 6 months or so. So creating the capacity in there is going to be very difficult. The other thing I think we also mustn't forget about is actually if we are going to ask patients to take some responsibility for their care, and lots of people want to, but there is quite a large cohort of people who don't really want to take responsibility for their care. And we will have to ask them to start doing this and say that we are expecting them to do that. And I think that really is it's a massive change in culture. The NHS has always been there just to provide. If we're changing the dynamics of that, I think it's a big step. I'm not saying it's the wrong thing to do, but there are quite a lot of hurdles along there that for us to circumnavigate.
Thank you, Carl, and thank you everyone for staying this late to listen to anything that I've got to say. Really appreciate it. So I'm obviously the sort of primary care dude on this panel, and Mel, you kind of asked me to comment on a few things. So let me just start by just saying that and I know you won't believe this, but I've just completed 30 years as a GP in my practice, all right? So, and I know you're all shocked. I appreciate
long service.
But do you know what? The point about me saying that is I have seen a load of stuff over 30 years that I know just doesn't work. And I've seen some stuff over that time which I think might work. But the sad thing is, every few years something happens and we forget everything that we learnt before. Am I right? Thank you. So one of the things that I wanted to just talk about, Mel, if that's all right, is this kind of concept of clinical integration, which is, I think, why we're on this panel. And you know, in the early phases of my career, the first sort of decade or so, it was very easy to have a clinical integration conversation. Do you know what we used to do? We used to actually talk to each other. You know, I could phone up Carl. You know, Carl was probably still just at medical school then, but I could phone up his predecessor, and we could actually talk about what mattered to the patient in front of us. Actually, trust each other to kind of recognise our skills and competencies, and we did not have to transact that relationship through some bureaucratic process that actually fragments care to the point that no one knows what the hell's happening anymore, right? So that was the first 10 years of my career. And you know what? I really enjoyed that. I really enjoyed those relationships. Then came the middle bit of that career, where actually people started to get into processes, generally managerially led, not really focused on patients, but very much focused on trying to simplify transactions and trying to improve productivity across providers. And kind of we all know what happened then. And in the last 5 years, I think there's a glimmer of hope, okay? 'Cause we just heard from Richard, there's quite a lot of focus now on the things that matter to people, and not just the things that matter to the institutions or the providers of care. So I think if we can learn from the past, we've got an opportunity to do things differently. So I don't want to kind of go on about this, Mel, but I just wanted to give that sort of relatively important historical perspective, and then we can pick up other bits in the conversation.
Well, I think the thing you've alluded to that's like you say, perhaps missing or forgotten is the importance of communication. So I suppose, how could digital help that now? What would you be looking for the digital to be able to do that could enable you to have those really rich conversations once again about your shared patients?
It's probably not that complicated, to be honest, I don't think. I mean, you know, with the advent of...
Simple's good.
advent of, Teams and Zoom and all of those kind of things, I mean, we've completely changed how we are interacting both with our patients and with our colleagues now. So it probably won't take that much to do. I think the bigger problem is how the system decides that it wants to fund these things, because at the moment we are all activity-based, each widget, and therefore each institution wants to protect its own financial budget so carefully. But what we've got to do is break down the barriers between the institutions and talk about shared care rather than handover care for institutions to make money. And that is the difficult thing that we've got to get to now. Whether that's a digital solution, I don't know, but it's a crucial thing, because in Hampshire we've been running what's called a linked specialty programme, which is where we've been trying to get GPs to work with specialists over a 2-year programme, both to develop their own expertise, but then to deliver services in the community back within their primary care networks. Everyone who's gone through the system absolutely loves it. But then when it comes to actually setting up the service in the PCN, it's virtually impossible because we don't know how to fund it. You can't just take money out of secondary care because secondary care are part of that thing. You've got to fund primary care in order to do it. And I can't find a finance director anywhere who can come up with a solution to this, but it cannot be that difficult.
Mel, really important question. I think we've just heard, haven't we, through the course of today, that technology's got a really important role to play across a number of elements of a care pathway. So there are tools and products and applications that support self-management and build capacity in our patients and in our communities, right? So we all know there's a plethora of those, and they're important. There are, as Maureen Baker was saying just before this, a number of tools that help people to monitor their own conditions and look after themselves when they need to with appropriate guidance and support. Then I think there are a bunch of workforce-facing tools. Those are tools that enable colleagues from whichever sector, and not just doctors, but other professional colleagues, to actually interact with each other in a moment in time to support each other with sometimes the difficult decisions that you have to make with patients and their families or their carers about something complex that's not straightforward. So I think we need to kind of look at those and see how they work and judge that by the impact it has on the day in the life of a member of our workforce, okay? And to see if we can improve, not duplicate or add, but improve the workflow on a busy day that our colleagues are kind of working through. And then the final bit of that, of course, is all the back office automation. And I don't mean, I'm sorry if I've got that wrong, but you know what I mean. There's a bunch of stuff around data, about processing, about administrative tasks, about scheduling, about creating appropriate sort of capacity that we could do. Now, that's what I would call an ecosystem of technology. But the whole design around that is, as Richard was saying, improving outcomes for people, which we're all desperately trying to do, but also then improving the satisfaction of our workforce to kind of have a better day at work. And I think we could all get behind that, couldn't we? I mean, why would that be difficult?
I mean, what I've heard is the word design quite a lot, and I want to bring Richard back in on this conversation, because I'm looking at this panel, I'm hearing the tales of 3 decades of primary care, and we've got ICS, secondary care, primary care, all represented here. And I think designing services and pathways that deliver the outcomes that the patients want, we want to see, is really, really key. So how do we make sure that the user-centred design, it features all the way through what you're describing here?
Yeah,
Sorry if that's a tough one. I mean,
no, it's not. No.
It's really important to bring that all together.
You'll know better than I. We know intuitively when we deploy digital solutions in a way that augment the experience for clinicians and patients, and that's not a surprise or a secret. It comes with graft. It comes with people, process, and technology combined to drive great outcomes. And I think the NHS generically needs to hold its hands up and to reflect that sometimes we've lent too far into seeing technology as an end in itself, and the deployment of the technological solutions has been overcooked, and undercooked is the engagement around user-centred design and working with the people, engaging with the patients or the clinicians or the people we're working with, and then really testing the processes to destruction through an agile process, which gets us to the outcome we want to achieve. And I'll hold my hand up, Leah Culper, I've been part of a system that has procured solutions and then patted myself on the back that, great, I've bought a great piece of technology and here's threepence to deploy it. And then I'm surprised when someone turns around about a year or two later and go, well, we've deployed widgets on every laptop in clinical information systems, but no one's using it. In fact, it's adding to the dysfunctionality and experience. Clinicians hate it and patients just don't know it exists. So I think I know at the heart of what we're trying to achieve around the elective recovery piece, Mel, is to harness that people, process, technology solution. Recognise we've got a 3-year plan to reduce our waiting lists and to improve the experience of patients, and recognise that user-centred design and putting the person at the heart of this is a core tenet, one of the 4 core pillars of the plan, and digital is like a sticker, is stuck through that like a stick of rock in terms of our focus. So really happy offline to talk to people about some of the practical solutions, but we can never move away from people, process, tech as a kind of the 3 cornerstones of our delivery.
So I've got a whole bunch of questions I could ask you, okay, but I think you probably have as well. So I'm just going to come to perhaps Nav and Carl once more, if I may, and ask you both from your primary and secondary care kind of perspectives, what does giving, again, perhaps it's that paternalistic, we're giving you control, what does the patient taking greater control of their care mean to you as a primary care clinician, first of all, and as a secondary care clinician? And then once we've perhaps drawn a close to that discussion, I'll open the floor for the last few minutes. I would say that if we all promise to run up the stairs, we won't be late for Simon Bolton's fireside, because I want to squeeze this conversation out dry, if that's okay. So now, do you need to repeat the question?
No, I think I got the sense of that. Thank you, Mel. So what does it mean? I mean, I think these are difficult. I mean, we all know what the words sort of mean, but actually implementing things that actually matter to people is always harder, isn't it? So, I mean, can I just give you a little anecdote? I started as a GP in 1991 in East Merton. The life expectancy gap between the people I look after, compared with the richer part of town, 1.7 miles down the road, was 7.7 years on average then. 1 year ago it was 9.4 years. So that gap has widened, not narrowed. And that's not the fault of me or my practice. Okay? So there's something called the broader determinants of health. There are things that impact on people's lives, such as having a house, having a job, having a family, someone that cares about you. And I guess the reason I'm saying these things, Mel, is that sometimes it's just easy to think that you can implement a piece of technology, a piece of kit, and things are going to be all right. Well, actually, and I know we don't think that, but, I think there's a very difficult scenario that goes on in people's lives, not just based on affordability and how people access and uptake things that make some of these things very difficult. So what does empowerment mean to me? Well, I think I know why some of those inequalities exist, okay? And people are not homogenous, all right? And people have different needs. And different families and people within those families have different needs. And we must stop trying to treat everybody in a one-size-fits-all approach. We've got to be a bit more sophisticated to understand what types of access systems people want, what type of uptake systems people want, what tools they need for self-management and support. Are they culturally relevant? Are they relevant to the ethnic disparities that exist? So those are huge challenges. But if we're going to address health inequalities, we're going to have to get quite granular into that level of detail before we start to think about adopting, tools that are going to empower people.
Thank you. Carl.
I would agree very much with that. And one of the other important points is the patients come to see me and they cannot understand why I cannot see their interactions with the mental health team or the drugs and alcohol team or whatever. So I think it's a difficult audience to say this to, but I think I would make it a crime not to share data rather than a crime to share data. Because for us, it is an absolute nightmare if you're trying to put a community service around people with complex needs, particularly if they've got mental health, particularly if they've got drugs and alcohol abuse and chronic disease. We just hand people around from one thing to another. No one knows what they're doing at all. So we've got to break this thing that IG is everything. I think it's a bit like the pandemic to say that infection control is everything. We have completely neglected all the people with chronic diseases during this and focused on one thing. We must not focus just on IG. We've got to get much better at sharing the data. And our patients want us to do it. They cannot believe that you cannot see a CT scan or an interaction with a mental health practitioner on your hospital database. They just don't understand it. It's completely crazy.
Yeah, and we heard that this morning. If use my data if it's going to better my health. Use my data if it's going to help me or my family. Or the people I love. So, yeah, that's absolutely cut through today. So I said I had lots of questions. I think I'm going to drop you a massive hint. We've got 2, possibly 3 public health, population health experts on this table. And I think what I wanted to really perhaps pick up in a more open conversation now is really around, well, we know that one size does not fit all. So how perhaps can we really look at co-designing, co-producing services that are built around discrete population sizes that have specific health needs. Shall I come to you and then we'll go to the floor because we're doing all right for time.
Well, I think we need to understand our cohorts, and trying to understand the cohort is an incredibly difficult thing to do because you can't get the information. So that's what we need to work on. And I do think if we're going to go personalised healthcare, we need to go and talk to the patients who are going to be using these things, rather than designing a system that we think that they're going to need. And that to me, is the hardest thing to do at the moment, but that's where we need to put all our energy.
Yeah. Richard?
Yeah, so I'm going to wave the flag for integrated care systems.
Yeah, please do.
At this point, because
that's why you're here.
I would reflect that prior to integrated care systems coming into existence, and I can be part of the establishment of an integrated care system, and less an STP for a number of years. There was no organisation or no body that was genuinely involved in setting strategic ambitions and expectations for a population that, under which you can really do kind of population health management. And I would observe, an anecdote on this one, that the Hampshire Health Record, or now we call it the Care and Health Information Exchange, which sounds a lot less interesting. But the Hampshire Health Record, certainly when I was a CCG chief executive, was an incredibly rich set of content across health and care, which when harnessed with the capability to look at using population health management techniques, was world leading. I mean, I remember an Optum, the global president of Optum, coming in and saying, "You've got what? You've got 23 years of longitudinal care data of 3 million lives, of which you've got general practice, secondary care, social care, open source data," and they honestly couldn't believe the richness of this data and the ability then to genuinely mine that data to drive improved outcomes. And Carl will know in his hospital, we were just in fact hearing about cirrhosis of the liver and the ability to use the data within the Hampshire Health Record to identify individuals who are going to be late presenting with cirrhosis of the liver and lead to early intervention and supporting life-saving capabilities in that space. The fact that we can look at de-identified data and spot who we think might well be presenting a late presentation of cirrhosis of the liver, but we're not able to mine it to bring it into the care workflow is a catastrophic challenge that I think we're beginning to tackle now. But I don't think we've curated these data sources and given them the genuine centerpiece in a health and care system which is focused on wellness and improving outcomes as opposed to information to support treatment and illness. And I think, therefore, integrated care systems, if they are not building population health management and curating integrated care data sources to drive that focus on reducing the care gap, improving the kind of wellness and early intervention, then they're not fit for purpose, and they've missed probably their greatest opportunity in a generation to drive a change in experience for people.
And I think we heard this morning, and a friend and colleague, Breed O'Brien, said when we think of health, actually we're talking about illness, and so we've really got to shift that dial, as you say, much closer to the population health end of the spectrum. So if we go on double speed, we might fit 2 questions in. So can I ask, yes, gentleman at the back, I don't know if I have a roaming mic, but if you want to stand up and introduce yourself, where you're from, and who you'd like, if anyone, to direct the question to. I'm going to pass this to you. Thank you, Brigitte.
Hi, my name's Aaron. I work for the Brain and Spine Foundation, a charity that supports anyone that has any type of neurological condition, and we try to work collaboratively with a lot of other charities. We're working very heavily around user-centred design in our own development right now. But one of the key things that keeps on coming out in our work that we do is, first of all, the term health care rather than health and care, because I see we've got ICSs, we've got secondary care, we've got primary care, but the social care is often never talked about in these things, and the whole breakdown of health and social care and that lack of communication between those is bad enough. I'm glad they talked about the nightmare that is the databases, that you guys can't see it, and if I speak to my sister, for example, she's thinking, why can't they find out about, she was only asking me last week about this, why can't they find out and know about this? And I have to repeat it. They have to repeat their story. So my question is around, why aren't we using the term health and care? And then secondly, stop using the word patient and start talking about the word person and people, because that widens the conversation with people and with them, because it stops medicalising the conditions or the person.
Agreed. I'm very careful in never saying, someone's got diabetes. It's a person with diabetes or a person with, whatever condition it is, because it actually does change the mindset of how you approach that problem. So agreed. I just wanted to, Mel, if I could just sneak in here quickly about population health stuff, if that's all right. It's just that I think the whole point of population health management is to build a rich picture of your population. You can do that with quantitative data and algorithms and all the things that happen, and that can happen at various population levels. But sometimes you have to get really quite granular because the picture changes at a postcode or at a group of households, okay? And that's when you need qualitative information that comes from your wonderful charity and other people who know the neighbourhood and what's going on. That's not on any database, and yet that's really important information to know. Who's lonely, who's not got heating, who's got a roof that leaks, who's got no family connections. Where are we going to find that information unless we go and actually ask people? And the great thing about general practice is we know who they are, we know where they are, we know how they live their lives. And actually that's kind of something that we all need to take much more stock of.
Yeah, I'd also like, you're absolutely right, that word on the top, that left-hand corner should say person, so absolutely point acknowledged. There's time for just one more question, I'm afraid, and then we really do need to rush upstairs.
Hi, my name is Zahib Kikiba. I'm a GP in Camden, GP partner, also CCIO for North Central London. So a huge iceberg has kind of built up over the last 10, 20 years, full of unmet needs, patient demand, and the concern is a lot of these patient-facing digital enablers would unearth this huge thing. And the classic example is, when online consultation was pushed in 2019, you will find practices on their hands and knees couldn't cope with the demand. So the assumption was patients will know when to contact their GP and telephones will go down, but actually everything went up. And we know practices were really, really struggling with that. And we have a struggling workforce. So, we have junior doctors holding 3 bleeps. We have GPs doing 12 hours. And increasingly, these doctors are moving to the private sector. We're losing GPs regularly. And I'm sure Nav can echo that. So, I certainly think population health management and proactive care will help, certainly. But I think literally over the next 5 years, there's going to be an explosion of demand. We're going to tell patients, be in charge of your care and let us know when something is wrong. Well, the reality is, I work in central London, health anxiety has gone off the roof. People are really scared. So, before having to wait, an hour on the phone to get an appointment through reception, etc., when you have an app to just say you've got, a little spot on your foot that you're worried about cancer, you could just put it through an app. And that lands with the GP. So I'm just highlighting, frontline clinicians are telling me to have a reality check, and I'm a GP, as well as being a commissioner. So I'm just interested to hear from Richard's perspective. Is this being thought of at a high level, and how are we going to manage this with a workforce that's really struggling? And echoing Carl's point, there's a 6 months waiting list. That's not going to go away. And these digital enablers are going to make things worse. I think we should be careful with the assumptions that patients know what's right for them. Yes, that might be the case, but a lot of patients don't know, and health anxiety is going up. That's all. Thank you.
If we just have time for...
Yeah. Well, yeah, I mean, I think it's a brilliant response. I think nationally we recognise that we're not going to be able to grow our workforce in the way in which we would want to do. So if that's a presumption, then there are 2 dynamics which are changing. One is the way in which we use technology in order to support our existing workforce to work in smarter and more effective ways. And the second is how we then hook up kind of biomedical research in order to drive more effective practice and better treatment solutions. Beyond that, there isn't much cavalry coming over the hill. We're not, irrespective though we are seeing some step change in overseas recruitment, it's not a long-term and sustainable drive. So I guess that's why I'd echo back, technology is not an end itself. The end in itself is hooked up technology to support the outcome we want to achieve. And if I take we've heard about the AI set of solutions. AI, I think, once we've got through some of the stages of kind of testing, accreditation, experiential, has the potential to, in radiology, for example, to allow radiologists to read more scans more effectively, not replacing them, but to create space for clinicians to focus on critical elements of work. Similarly, in patient-initiated follow-ups and the work we were talking about, personalisation, what we're not saying is we're not going to give patients opportunity and experience, people opportunity and to experience access to care. But what we are doing is saying we want to empower them to choose when they want to come, and that should free up more clinical time in order to get their teeth into upstream activity. So I'm not naive, and we're not standing here saying this is a beautiful world where we've cracked it. But I think that we've probably understated the ability of digital and technology to drive the optimization of clinical and non-clinical work round. And I think the kind of piece that stands out for me is, working in a hospital, we've bodged things all the time in terms of we find workarounds. All the time we're finding workarounds. And technology gives us the opportunity to avoid those workarounds. RPA, some of the kind of process engineering stuff allows us to get rid of all of the stuff which is now in the hands of administrative staff who create unsafe and ineffective and less suboptimal solutions. So I think there are no other cavalry coming over the hill to drive this. I think it's about our ability to be clear about what our goals and outcomes are, and then tying the digital set of solutions to drive those outcomes, rather than pinning our hopes on technology and hoping that in and of itself drives the outcome that we're looking for.